Hello, and welcome to your training video for neonatal intubation. Please remember at the conclusion of this video to take the online quiz. You need to complete that quiz prior to coming to the training session. These are our three main goals that we would like to accomplish with this video. We want to make sure you know the differences between the adult and the neonatal airway. We want to make sure that you have a good review of the technique and equipment needed for intubation, and then we'll go over some of the common mistakes and complications of intubation. Here you can see the common discrepancies between the neonate and the adult airways. Notice the posterior portion of the tongue is larger in the neonate. Notice the angle at which the vocal cords lie in the neonatal airway. The larynx is higher in the neck, making it more difficult to see. The occiput is much more prominent in the child, and the narrowest portion of the airway is at the cricoid ring, which is below the vocal cords, whereas in the adult, the vocal cords are the narrowest part. This comes into play when making sure you have the correct endotracheal tube size. Also, when looking at the pediatric glottis versus the adults, you can see the pediatric glottis on the left-hand side of your screen. It has a typical omega shape outlined here that is very floppy and not really full of cartilage, whereas the adult epiglottis does not have that omega shape and is full of cartilage, easy to lift out of the way. There are a number of indications for endotracheal intubation. I expect that you know most of them, so we'll review them quickly. First and foremost is a failure to oxygenate, followed by a failure to ventilate, and go straight to endotracheal intubation, such as with diaphragmatic hernia or meconium aspiration, cardiorespiratory instability, such as APGARs less than 3, congenital malformations, upper airway obstructions, airway protection, certain types of drug administration, and if there's an elective procedure for the patient. There are a number of items that you will need for a safe intubation. You can remember some of these with the mnemonic MISS-MADE. First, monitors, cardiac and pulse oximetry, suction and something to secure the airway with, machine, which would include the tools you're using to oxygenate and intubate, airway, which would be your endotracheal tube. You always want one size above and one size below what you had planned. You also need to auscultate following intubation. You'll need an IV to be able to give fluids and the drugs needed for intubation. Here is a visual of all the things that you need. Please note the monitor in the upper left, the ambu bag in the middle. Then next to it is the suction machine. There are variable types of suction, and you will decide which one you need at the time. You can see various types of securing devices also located next to an LMA. You'll also see different size endotracheal tubes, all with a stylet in it. Your end-tidal CO2 detection, tape, your baby, appropriate sized masks, blades, and so on. Here you see two types of blades that we have available to us, the Macintosh and the Miller. Typically, we use the Miller blade when intubating neonates. This is because you are going to lift the epiglottis up out of the way, and the individual point on the curved Macintosh would damage the airway further while lifting up. Also note, there is green on both of those blades, and the handle next to the image also has green. This indicates that they are fiber optic blades. The light source is located within the handle of the laryngoscope, not at the tip of the blade. This would be a conventional incandescent laryngoscope where the light source is inside the blade, and inside the handle are batteries. No light source. Notice there is no green on either one of these here. Never leave it on, as the bulb will get very hot and can burn the mucosa of the infant. And finally, when using one of these, always check the bulb. Make sure it's screwed in tightly and illuminates. When you choose the correct blade size, you need to keep this in mind. A number 1 is typically for a full-term infant, a number 0 for a preterm infant, and a number 00 for extremely preterm. Please note in our image, we are looking at a size 2 Macintosh blade. As we mentioned, the Mac is great for going in behind the epiglottis, lifting the tongue and jaw, and allowing the epiglottis to follow because it is full of cartilage in the older patient. In the neonatal patient, we prefer to use a Miller blade, which picks up the epiglottis out of the way, as seen on the image in the right. These are examples of endotracheal tubes that you may come across. Please note, the one on the top of the image is a cuffed endotracheal tube. We do not use these types of endotracheal tubes in neonatal patients. In the pediatric ICU and the ER, they are the preferred, but not in the neonatal population due to the injury the cuff can cause to the airways. When choosing what size endotracheal tube to use, remember to use the rule of 1/10 of gestational age. So if you had a 35-week infant, you would probably use a 3.5 uncuffed endotracheal tube. On your tracheal tube, you'll also notice hash marks. There are different types of endotracheal tubes, and we cannot predict what we may have when you're watching this video. On the left, you see 3 hash marks. Aim for the middle one. On the right image, there is a dot on the cuff tube, and on the next tube, you can see a long dark black line and then a small one. All arrows are pointing at the particular marks. In the third image, you would want to aim for between the 2 black marks. Endotracheal tubes are called by their size. The example here is the 6.0. The 6.0 refers to the internal diameter size. Now, as we'll talk about in every procedure you do, positioning is always the most important aspect of any procedure. If your positioning is wrong, you will not be able to intubate. Here, I would like to draw you to the axis of each one of the parts of the airway. The oral axis, marked as O, is at a very acute angle to the pharyngeal axis, marked as P, which is also at an acute angle to the laryngeal axis, marked as L. You need to have all 3 of these axes lined up in order to be able to see into a child's airway. By placing a roll underneath a neonatal's shoulders, you will start to align these axes. See how you have the pharyngeal and laryngeal airways axes now lined up. In order to get the oral lined up, you need to insert an endotracheal tube with the laryngoscope. As we place our laryngoscope in, our oral axis will align as you pull the mouth and chin up. Let's move on to reviewing the procedure. When you start your procedure, always pre-oxygenate. The only caveat with this is if the patient has a cardiac cyanotic congenital heart lesion. Make sure you apply monitors or someone is applying monitors while you are bagging. Do a brief timeout, ensuring you have the right procedure and patient. Make sure the position of the neonate is appropriate. A roll under the shoulders is not an option, it is mandatory. Suction the oropharynx and nasopharynx. Without a clear view, you will not be able to see anything. And finally, Give medications as needed. Try to use a minimum dose of atropine, but make sure that you use the atropine, as your patient may go bradycardic. If you need to paralyze a patient, make sure you're able to bag them first. Perform your timeout. Apply the monitors. Position the patient appropriately. Make sure you're pre-oxygenating and using a bag. If you have a neopuff available, this may be an acceptable option. Suction the infant. If you do not suction, either with the bulb syringe, Yankauer, or French, as shown here, you will not have a clear view of the airway. When getting ready to use your laryngoscope blade, make sure that you grab it with your left hand. While you may be right-handed, it is the convention to hold the laryngoscope in the left hand. That is how they are designed. Then, while standing over the infant, insert the blade on the right side of the mouth, not necessarily trying to visualize the cords at first, but pushing the tongue to the left with the side of the blade. Notice the red arrows pointing to the side of the laryngoscope blade in the lower image. Frequently, this looks like a small tunnel. This is not a tunnel to put the endotracheal tube through. This is a window into the airway that will also push the tongue out of the way. You will come from the side of the mouth with the endotracheal tube, nowhere near that passage. You will take a step back and lower your head to the level of the table. Now your eyes will be aligned with those three axes. You will then slowly advance the laryngoscope, visualizing the epiglottis and then lifting it out of the way. You will not rock the laryngoscope. You will not rock the laryngoscope. Please see the correct way to move your laryngoscope as shown on the left-hand side. You will lift up and away. You will not rock the laryngoscope. And if you can imagine the axis as we drew before, you would be getting the laryngoscope in the way of seeing. Now, as you go in, you will see the vocal cords, the cartilage, the epiglottis, and the tongue. You will pass your endotracheal tube through the vocal cords. Prior to doing so, you're looking for meconium. You're also looking to see if they're moving or paralyzed. If they're moving, you run the risk of spasm and not being able to bag the patient. Although in the neonate, this is rarely an issue. Someone passes you the endotracheal tube, and then you smoothly place it in through the right side of the mouth, down into and in between the vocal cords. You will pay attention to the hash marks. However, in the extreme situation, it is often difficult to forget to pay attention to the hash marks or vocal cord guide. Therefore, we use an estimated depth on how deep we should put our endotracheal tube. This is 6 plus the weight in kilograms. So if we had a 3.5 kilo infant, you would want to place it at roughly 9.5 centimeters. Sometimes you won't be able to see well when you want to put the endotracheal tube in. You'll definitely have better success with good suctioning of the pharynx, maybe gentle lifting of the scope, and potentially gentle pressure on the cricoid/hyoid bone area. Also, you may need to just come out, bag the patient, and start again. While doing this, it is very important not to wait too long. Each intubation attempt should only last 20 seconds, reducing hypoxia to the brain and other organs. I find holding my own breath is helpful. And when I need to take a breath, the patient needs to breathe. Once the tube is in, you need to make sure that you have actually got it in. You may see direct visualization of the tube passing the vocal cords. You can use an end-tidal CO2 monitor, either the one shown here or continuous monitoring. You can look for chest rise on bagging. You will auscultate bilaterally. You will look for endotracheal tube condensation, although this is not very reliable with gastric secretions. Finally, you're going to get a chest x-ray, and you're going to look to make sure the endotracheal tube is around T2 or midway between the carina and the clavicles. This is a quantitative end-tidal CO2. Looking at the lines, you'll see on the right-hand side there is inspiration and exhalation, indicating that you are in the lungs. The left indicates no detectable carbon dioxide, which likely would mean you are in the esophagus. The chest x-ray here shows the endotracheal tube in the trachea, but is it at the right side and spot? Well, if we look between the carina and the clavicles and go midway, we're almost there. So while it looks like we're below T2, we're almost at the midway point between the two. I would not move this endotracheal tube. Now, although we've already gotten that x-ray, I sincerely hope you secured the tube. You can secure the tube with many different types of devices. Tape always works. So, after you've secured, you're going to reassess that the endotracheal tube is still in, which is why a continuous end-tidal CO2 is very helpful. You're going to continue to assess the neonate. Are they improving? Are they pink? Is their heart rate increasing? Which is the best indicator of correct placement and improving oxygenation status. Please note, the vital signs on that monitor definitely don't correspond to a good neonate. And you're going to continue resuscitation as needed following your NRMP guidelines. There are a few common problems we're going to cover quickly. One, you're going to fail at intubation. You're not going to see anything when you go in there. So you got to make sure that you're assessing if you're actually using proper positioning technique. Because as we mentioned, position is the most important thing with any procedure. Are you hyperflexed? Are you hyperextended? Are you down into the esophagus past the normal glottic opening? When you're not sure, come out, ambu bag the baby, and start again. Did you have an esophageal intubation? While this is not detrimental, it is if you do not address it immediately. In this case, you would have to take the endotracheal tube out, continue to bag the infant, and start again. The tongue can sometimes be very cumbersome and obscure the entire airway. Always make sure that you sweep the tongue to one side with the blade. Do not squeeze the tongue underneath the blade, causing damage. I'd also like to highlight here, this is the area of the blade that we were discussing that looks like a small tube. You are not sticking your endotracheal tube down this area. You would be coming in through the side of the mouth. This area is to make sure that you can see the vocal cords as your tube comes in from the side of the mouth. And finally, complications of intubation are numerous. The most common ones would be a simple mucus plug or blood, an accidental extubation, which can happen at any time after the intubation, a main stem bronchus intubation, which we're going to hope we don't do based on our vocal cord guide and chest x-ray following procedure. You can have lots of soft tissue injury, especially if you're anxious during the procedure. Please make sure you are always gentle with the infant. No matter how worried you may be in the situation. A pneumothorax, while not too common, is still a very common problem that we come across with intubations, especially with people who are over aggressively bagging the patients. Please remember to bag calmly, even though it is a scary situation. Hypoxia may occur right after intubation. Continue to bag the patient as long as you know you're in the correct position. Make sure your oxygen is on. You can cause worsening infection. You can cause a worsening pneumonia. You can cause an aspiration pneumonia due to your intubation. Make sure you are covering the patient appropriately for infection. Failure to intubate. We are not all skilled at being able to place endotracheal tubes. I find it extremely helpful to always have 2 skilled technicians at the bedside when intubating a patient. If that means that you and your attending, or that means your attending and an anesthesiologist are at the bedside, so be it. Finally, you can always have a death with intubation. If it is a difficult intubation and no one is able to place the endotracheal tube, the patient may die. They may go into cardiac arrest while the procedure is going on. It is a very difficult and dangerous situation to be in. That's why you are doing this now, and you will take every precaution in the future and have the supervision you need when placing an endotracheal tube. Finally, proper positioning is critical to any procedure, especially a successful neonatal intubation. Call for help early. If there are any congenital abnormalities in the patient, don't try to do this alone or by yourself. Call someone immediately. Remember, you can always ambu bag an infant as long as you see their chest rising and their oxygen sats staying up. Practice makes perfect, and we continue to invite you to come to the simulation lab in your free time, which I'm sure you have a lot of, to practice the procedure over and over and over until it is in your muscle memory and you no longer need to think about it. This concludes our slideshow. Please remember to click on the link above to go to the quiz. Please remember to also fill out your name on the quiz. On the right-hand side, you'll see an additional video on neonatal intubation that I find extremely helpful, and I hope you take the time to watch. On the left is the link to the other video for lumbar puncture. And finally, please remember to subscribe, like the video, and sign up for alerts if you want the most recent and best videos on medical education.